So, hi, good evening, guys. This is a special session on cardiac murmurs brought to you by the White Army, including its subset of MMM, that's Medicine Made Memorable, with me, Dr. Akshay Rao, your faculty for today's session. So, getting straight on with it, we'll discuss a little bit about cardiac murmurs and clinically relevant aspects about the examination findings. So, because a lot of times we know that, especially undergraduate students and even the first year postgraduate students of medicine, they find it to be a little daunting to be able to detect a murmur, to be able to tell what the cause of the murmur might be, what might be the underlying diagnosis, the underlying cardiac lesion, whether there's a cardiac lesion in the first place or not. So let's try and delve into these issues and related aspects about cardiac murmurs in this session today. So starting off with, what is a murmur? A murmur is something that produces a sound, right? So you know that the heart produces sounds of its own. So we know about the first and second heart sounds. These are normal. But if there are some abnormal sounds that are produced in within the heart, and that is arising as a result of turbulence. So normally a streamlined blood flow, let us say the atrium is supposed to receive blood from the right side. The right atrium receives blood from the great veins. The left atrium receives it from the pulmonary veins. Then it passes along this blood through the AV valves into the respective ventricles, right and left ventricles. And from there on, they get pushed into the great vessels, the great arteries, the aorta, the pulmonary artery. So all this is supposed to be so streamlined that you're not supposed to hear the human ear at least is not supposed to pick up any abnormal sounds due to turbulent flow. It's all streamlined. So as long as the heart is compliant and there is no obstruction, there is no abnormal flow, that means it's unidirectional, it's one-way flow from the right atrium forward into the ventricles. That means the right ventricle, then onwards into the pulmonary artery. Likewise, the left atrium, left ventricle into the aorta. All this is one unidirectional flow. It should not produce any sounds. But if there is some amount of turbulence, for some reason, the blood flow is not streamlined, it will produce a sound. And this is what is known as a murmur. Okay, so murmur most often will be indicative of an intracardiac lesion. So there is some problem within the heart, most likely some problem within the heart, which is producing the turbulence, leading to this abnormal sound. So sometimes that it may so happen that there is an exception to this. There may be, without there being an organic lesion within the heart, there may be some amount of turbulence produced, and that is producing a murmur. So we'll discuss that also. One thing you should try and appreciate is what is the difference between a sound and a murmur. A sound is a one-time event. So if you're talking about S1 or S2, it's a one-time event. Whereas a murmur is something that persists through the time, right? So for example, if you're talking about pansystolic murmur, if this is the first heart sound, this is the second heart sound. It's a one-time sound, right? One-time audible event. Whereas the murmur will be right from the first heart sound towards till the second heart sound. So this is a murmur. A murmur is not a one-time event. It is continuing in time. And that is what you're hearing. That it's because of the turbulence, right? So that is the difference between a heart sound and a murmur. Sometimes we have abnormal heart sounds like S3 and S4. Okay, S3 sometimes can be physiological, but S4 is always pathological. The fourth heart sound is always pathological. Please remember that. But third heart sound can be normal, even heard in young, healthy adults. Okay, so as we were discussing, abnormal sounds produced due to turbulence most often indicate that there's a problem within the heart. It's an intracardiac problem. But occasionally there may be no problems within the heart, and yet the flow may be turbulent. For example, in hyperdynamic states. So in hyperdynamic states, most commonly in anemia. So in patients with anemia, you may be able to auscultate a murmur, and which is known as the hemic murmur. Hemic murmur, right? So hemic murmur can be even without there being an intracardiac abnormality, purely because of the turbulent blood flow, because of anemia. So most often does indicate an intracardiac problem. Sometimes the problem lies outside of the heart and yet produces a murmur. For example, in patent ductus arteriosus. So you guys know that PDA is a type of asynaptic congenital heart disease. Though the lesion, the shunt between the pulmonary artery and the aorta lies outside of the heart per se, there is still a murmur, in fact, a continuous murmur that is produced, yet not because of an intracardiac problem. So yet we denote it as a murmur only. So please remember, murmur is due to turbulent blood flow, most often a cardiac problem, sometimes without a cardiac problem, or sometimes a problem lying outside of the heart. Now, what is the difference? We learned about S3 and S4. These are one-time events in time, so they don't continue. They're just once that you hear those sounds. They're low-pitched sounds, both S3 and S4. They're low-pitched sounds. You have to, if you're using a chest piece, a stethoscope with a chest piece which has a diaphragm and a bell end, you need to pick up low-pitched sounds like S3 and S4 using the bell of the stethoscope. Please keep that in mind. Low-pitched sounds heard using bell of the stethoscope. What is a bruit? Bruit is the same turbulent blood flow which is heard within arteries. So if you hear an abnormal sound, so normally even if you press over your arteries, you may just about be able to make out the heart sound. For example, if you auscultate your own carotid artery, you may be able to make out the heart sounds, but not a murmur. If you're hearing a murmur within an artery, not arising due to an intracardiac problem, then it is called a bruit. So for example, renal artery bruit. So a renal artery bruit will be as a result of renal artery stenosis. So renal artery bruit or subclavian bruit. So renal artery or a subclavian artery bruit. Subclavian artery bruit may be heard in patients with Takayasu arteritis, or sometimes a carotid artery bruit, again because of carotid atherosclerosis. So these are all examples of bruit. A hepatic bruit is heard due to hepatocellular carcinoma, right? So these are not murmurs. These are sounds produced within arteries, hepatic arteries, due to the hepatocellular carcinoma. The HCC is demanding too much of blood for its growth, and that's why there is turbulence produced within the artery. What is a hum? A hum is the same turbulence which is produced within a vein. So for example, in patients with portal hypertension, there may be a hum that is heard, especially in the mid-epigastrium, a venous hum due to portosystemic anastomosis. So turbulence may produce sounds within the heart, outside of the heart. Terminologies are different. Murmurs generally indicate a problem, or at least the turbulence is being produced within the heart, with some exceptions, for example, in patent ductus arteriosus, correct? So whenever you're describing a murmur, so supposing you're an undergraduate exam going student, or even if you're a postgraduate of medicine, you're expected to describe a murmur. So you heard something abnormal, some abnormal sound on cardiac auscultation. You're expected to describe your findings. You have to convey those findings to your examiner, to your audience. So what are the different parameters or subheadings under which you're supposed to describe a murmur? So there's a mnemonic for this, SCRIPT, script. And this stands for S is sight, C is character. We'll discuss all this. R is radiation or conduction. So there is a difference to both of these. We will discuss. I is intensity. P is pitch and position of the patient that you're supposed to auscultate. And T is one of the most important, that is timing. Though it is at the end of this mnemonic, but it's one of the most important points. That's the timing of the murmur. Okay, and most murmurs are actually classified based on timing. Right, so describing any murmur under these 6 parameters, subheadings, SCRIPT. Okay, so starting with sight. So where are you hearing the murmur best? So you guys know that there are 5 main areas of cardiac auscultation, correct? So these are all basic points. So if this is the sternum, and let's say this is the second rib, this is the third rib, left and right, this is the fourth rib. Okay, so fourth rib, and below that would come the fifth rib, the fifth intercostal space would be coming below, right? So if I'm talking about intercostal spaces, let's say the second rib will join the manubrium sternum. So below that is the second intercostal space, then the third intercostal space, and the fourth intercostal space below that, and then the fifth intercostal space is below the fifth rib, correct? So the main areas of auscultation include the right and left second intercostal spaces. These are the aortic and pulmonary areas respectively, followed by the third intercostal space on the left side, that is the third left parasternal space. This is known as the Erb's point, or the Erb's area. And the fourth on the left parasternal space is known as the tricuspid area. The tricuspid area. And the fourth is tricuspid. And the fifth intercostal space is generally where the apex is. So remember, guys, Mitral area is wherever the apex is. So normally you expect the apex to be in the fifth intercostal space, half an inch medial to the left mid-clavicular line. So that is where you will place the mitral area. But in case of a pathology, for example, in a patient with mitral regurgitation, there may be a left ventricular enlargement, and that will push the apex downwards and outwards. So supposing if the apex now lies, the apical impulse, which is the lowermost and outermost point of definite cardiac impulse that can be palpated. So if the apical impulse now lies laterally displaced in the sixth intercostal space, then the mitral area will also correspond to the same area. Okay, so the mitral area it corresponds to the apical impulse wherever it may be lying. So if it's in the fifth intercostal, the apical impulse is in the fifth intercostal space, half an inch medial to the left midclavicular line, that's where the mitral area would be. If it is displaced, the mitral area will also get displaced along with it, along with the apical impulse. So it will correspond to wherever the apex is, apical impulse is, right? So in these areas, which are the murmurs where, or which are the areas where the murmurs are best picked up? So aortic area is best for auscultation of aortic stenosis. So valvular aortic stenosis, aortic area is very good area. But not to say that aortic stenosis cannot be picked up elsewhere. In fact, there is a concept called sash line. So in sash line, the murmur can be picked up anywhere from the second intercostal, right second intercostal space all the way till the apical impulse. So just like beauty pageants, they wear a sash, no, like that. So a line or an area across right from the right second intercostal space, parasternal space till the apical impulse, anywhere along that you may be able to hear an aortic stenosis murmur. Best heard, though traditionally we say best heard in the aortic area, that is the right second parasternal space, but you may even be able to hear it in the Mbbs area also. Not to exclude that Mbbs area may still be the best area where aortic stenosis murmur is best heard. Okay, what about the pulmonary area? That's the left second parasternal space. That is the best area for auscultation of pulmonary stenosis. So pulmonary area, pulmonary stenosis. Okay, so maybe we'll write it down here. Aortic area, aortic stenosis, pulmonary area, pulmonary stenosis. What about Mbbs area? Mbbs area combined is the best site to hear both aortic regurgitation and pulmonary regurgitation. Both can be best heard in the Mbbs area. Okay, so you need to be able to differentiate. If you are hearing a murmur in the Mbbs area, a diastolic, an early diastolic murmur, it may be both AR or PR. So how do you differentiate a right-sided murmur from a rather a right-sided cardiac murmur from a left-sided cardiac murmur? You guys just revise that point. I will come to it eventually. Okay, what about the tricuspid area? Both tricuspid regurgitation and stenosis best heard here, right? And finally, the mitral area is best for both mitral murmurs, that is MR and MS. So this is about the site of the murmur. Where did you hear the murmur? At the maximum intensity, site of maximum intensity. So some of the murmurs, they're well localized, but some murmurs may radiate or conduct. So in that case, you need to describe which area did you hear the maximum intensity of that murmur. That's the site of the murmur. Okay, so site may give you a clue to what the cause of the underlying lesion may be, or the cause for the murmur may be, and the underlying lesion, what it may be. Clear? So site of the murmur depending on these different areas of auscultation. Character. So C stands for character. Different murmurs may have different characters. For example, a mitral stenosis murmur has a rumbling character. So you won't forget it. The thing is, mitral stenosis murmurs are slightly difficult to pick up, but once you hear it, you won't forget it. It's a rumbling murmur. So it'd be like this, drr, drr, like that. So it's like a rumble. Okay, so you won't forget the character of a mitral stenosis murmur. Both an AR and an MR would produce blowing type of character. The murmur of both AR and MR would be blowing in character. Whereas aortic stenosis would produce a very rough and rasping type of murmur. Rough and rasping type of murmur. Okay, so we are predominantly sticking to the left-sided murmurs because in clinical practice, most often we encounter left-sided heart disease. That's where the turbulence is, no? So for example, wherever the cause or whatever the underlying etiology for the valvular heart disease, it will generally affect that side where the turbulence is more because of epithelial damage. So whether it's rheumatic fever or rheumatic heart disease, infective endocarditis, everything would prefer causing a lesion on the left side. So what we encounter in clinical practice is a left-sided valvular heart disease more commonly. That's why we'll be discussing or emphasizing more about the left-sided valvular heart disease producing murmurs. So these are the different characters that one can encounter on cardiac auscultation for murmurs based on character. What about SCR? R is radiation or conduction. What is the difference between these two terms with regards to murmur? So if a murmur is heard at a particular site, if this is the original site where the murmur is heard at maximum intensity, this is the original site. So for example, aortic stenosis. So if it is best heard in, let's say, the left or rather the right second intercostal space, parasternal space, right second parasternal space. From that site, if it is heard at a different site, but at same intensity. So you heard it at maximum intensity in the aortic area, and at the same with the same intensity, you can even hear the murmur also in the carotids. So you're auscultating the carotids, you're hearing the AS murmur with the same intensity as in the right second parasternal space. So at different site, but same intensity. Okay, this is known as radiation. Whereas if it is heard at a different site, but at a lesser intensity, then it is called conduction of a murmur. At a different site with reduced intensity. So reduced intensity, this is known as conduction of a murmur. So in the example of aortic stenosis, the aortic stenosis murmur, it's a rough rasping type of murmur, best heard in the right second intercostal space, but it may get radiated to the carotids, both carotids. So if you keep the stethoscope, the chest piece of your stethoscope over the carotids, you'll hear the same murmur as you heard it in the second right interspace, but you'll hear the same murmur also at a lesser intensity in the mitral area. So an aortic stenosis murmur conducts to the apex, that is the mitral area, but radiates to the carotids. Okay. So it's a relative difference, radiates to carotids. It's a relative difference, but these are the classical terminologies used. So if ever you're coming across these terms, that's what they mean. The clinical implication, maybe not so much, but just that you may be confused. So for example, you are hearing an ejection systolic murmur of aortic stenosis, both in the right second interspace, right second intercostal space, and you're hearing it at the apex. Okay, if this is the sternum, let's say this is the sternum, you're hearing it at the apex also, and you're hearing at the apex and the right intercostal, right second parasternal space also. So how do you know if they're two different murmurs or they're same murmurs? You are hearing them almost similar sounding murmurs, but at different intensities. Do they represent different types of murmurs, different lesions or not? So for trying to make out this difference, you can use a method known as inching. Okay, there's a method known as inching method. So inching method involves taking your chest piece or the stethoscope from the area of maximum intensity towards the other area. So for example, in case of aortic stenosis, first I'll keep my chest piece in the second right parasternal space. And from there, I've heard the murmur, the ejection systolic murmur. From there, I'll take the chest piece slowly towards the apex, inch by inch, I'll keep moving my chest piece. So I'll be able to appreciate whether the murmur is slowly reducing in intensity as I reach the apex. In that case, it is the same murmur that is getting conducted. Whereas what if there was another lesion here at the apex producing a systolic murmur? So I'm hearing a systolic murmur in the right second intercostal space, parasternal space, plus I'm hearing a systolic murmur in the apical area. So how do I know the same murmur or different murmur? When I inch from the second right parasternal space towards the apex, if the intensity of the murmur first reduces and then again it picks up. So it reduced and then it picked up. That means it's a different murmur. Okay, so if the murmur being produced in the apical impulse, rather at the apex, is different from what is producing the murmur in the aortic area, as I inch from the aortic area towards the apex, the first murmur's intensity will slowly come down, and then suddenly the intensity of the apical murmur will increase. As I reach the apex, the intensity will again increase. So this is known as inching method. It will help you to differentiate whether two different murmurs are there in these two areas, or is the same murmur getting conducted to a different area. If it is the same murmur conducting to a different area, the intensity will progressively reduce till you reach the apex. It will not pick up again. If it's picking up again between the two areas, there's a dip, and then it's picking up, then it is a different murmur. Two areas have a different murmur. Okay. So remember the difference, radiation and conduction. Now, when we talk about which are the murmurs which do get conducted and radiated, I already told you aortic stenosis murmur gets radiated to both the carotids and it conducts to the apex. In fact, that is known as Gallagher phenomenon. When the aortic stenosis murmur, I'll write it here. I hope this is okay. So aortic stenosis murmur, when it radiates or rather conducts to the apical area, apex, then it is known as Gallagher phenomenon. Gallagher phenomenon. So it in fact imparts it changes the quality of the murmur. It doesn't change the character, but changes the intensity and the quality of the murmur. It almost makes it sound like it's a musical murmur. So musical sound. That's how it's been classically described. So musical sound imparted to the same murmur from the aortic area, which gets conducted to the apex. It's known as Gallagher phenomenon. Okay. Whereas it radiates to the carotid. So radiation and conduction is all dependent on the direction of blood flow. So if you imagine from the aortic area, the blood is flowing into the aorta and into the carotids there from there on. So that's why the murmur sound is getting conducted, or rather it's radiating towards the carotids. Likewise, what about mitral regurgitation? The MR murmur will radiate to the back and axilla, left axilla. So that's again to do with the direction of the blood flow. The regurgitant jet, mitral regurgitation will produce a regurgitant jet from the left ventricle going back into the left atrium. That's not supposed to happen, right? It's supposed to be unidirectional blood flow from left atrium forward into the left ventricle. But if the reverse happens during the ventricular systole, left ventricular systole, some blood is regurgitating into the left atrium, that will produce a jet. That jet is generally directed towards the axilla and towards the back, especially when it's an anterior leaflet defect. So remember, the mitral valve has two leaflets. It's a bicuspid valve. So anterior leaflet, when it is damaged, the jet is directed posteriorly. Ulta, when there is a posterior leaflet damage. If the posterior leaflet is what is damaged, then the jet will be directed anteriorly towards the base of the heart. So anterior leaflet will produce radiation, or anterior leaflet defect will produce the regurgitant jet directed posteriorly and laterally. So that's why the radiation of the murmur is towards the back and the left axilla. Whereas if it is a posterior leaflet defect, it will radiate towards the base of the heart. Base of the heart meaning towards the right, or rather towards the left second intercostal space, left parasternal space. That's where the MR murmur will radiate. Okay, depending on which leaflet is damaged. But most commonly, it's the anterior leaflet that is damaged in causes of mitral regurgitation. Okay, so this is about radiation and conduction of murmurs. So try and make out whether the murmur is getting radiated, conducted, or if it's a separate murmur altogether by using the inching method. And examples of murmurs which do radiate and conduct are aortic stenosis and mitral regurgitation. Clear? There are some murmurs which are very well localized, like for example, mitral stenosis. Mitral stenosis murmur, the MDM murmur is very well localized. It won't, if you keep your chest piece just a little bit here and there away from the apex, from the mitral area, you'll miss the mitral stenosis murmur. That's how it is. Very well localized, easy to miss. Okay, next point is intensity. Intensity is described based on grading of murmur. So how do I say this murmur is more severe and this murmur is not so severe? It is by using grading. So traditionally, the teaching was grading is only applicable to systolic murmurs. But nowadays, more and more, it's acceptable that diastolic murmurs be also graded. So what are the grades? Basically, the two grading systems are same. So whether it's diastolic or systolic murmur, the grading system is out of 6 grades. Grade 1 is it's heard only in a quiet room. Okay. Only if you eliminate all the background noise. In a busy OPD, lots of noise, you can't hear a murmur. That's probably grade. Even though the murmur is there, you can't hear it. Then that's probably grade 1 by 6 murmur. So if you eliminate all the background noise, you take the patient to a quiet room only, then you can hear just faintly, you can hear a murmur. That is grade 1. Okay. Grade 2 is you can hear it with normal intensity. even in a usual room itself. You need not have to, even in the usual amount of background sound, you can still hear, pick up a murmur that is a normal intensity. Okay. Whereas it's very faint in grade 1. Here it is, it's the no, it's a normal intensity murmur. If it is loud, if it is loud, that means it's moderate. Okay. Grade 2 is moderate. If it is loud, but without a thrill, then it is grade 3. If it is loud and with a thrill, so no longer is this just a auscultation finding. You have to also palpate and see. Can you appreciate the turbulence? That turbulence is not just producing sound, it's also giving you vibrations when you palpate. So when you're palpating for thrill, you're supposed to use the base of the fingers. The base of the fingers, you'll place your palm over the cardiac areas, the different areas where you auscultate for the murmur. Somewhere you heard a murmur, you place your hand over there and see if you can pick up a thrill at the base of the fingers. If yes, then it automatically becomes minimum grade 4. If it's a loud murmur but no thrill, it is grade 3. So a palpable murmur is called a thrill. Okay, palpable murmur is a thrill. If it's loud and with a thrill, it's grade 4. Grade 5 and grade 6 are more of historical values. You don't come across grade 5 and grade 6 these days. But anyway, grade 5 by 6 murmur would be a murmur which is well heard with the chest piece in light contact, with the chest wall. So with the patient's chest wall. So the stethoscope in light contact itself, you can hear a very loud murmur and there is a thrill on palpation, then it becomes grade 5. Grade 6 is with with the chest piece a few millimeters away from the chest wall. So even just before you can place the chest piece over the chest wall, you can hear a very loud murmur. That is known as a grade 6 by 6, not very common these days. That's because many of these are because of congenital anomalies and they don't survive up to adulthood. Either they get corrected, the congenital anomaly is corrected, or the patient succumbs. So you don't hear these murmurs these days. But from historical point of view, this is the way the murmurs have been graded, okay, from the chest wall. This is 1 to 6, okay? So whenever you hear a murmur, you need to grade it. SCRI, I is intensity. You need to describe this is the intensity of the murmur. So traditionally, it was applicable only to systolic, but even diastolic murmurs are being graded. Remember, if you're an exam-going student, currently preparing for upcoming undergraduate exams, MBBS exams, your examiner would probably not be very comfortable having diastolic murmurs being graded. They will expect that you grade only systolic murmurs. That is a traditional teaching. But nowadays, even diastolic murmurs are being graded. So why this point? Why systolic murmurs were supposed to be graded and not diastolic? That is because, like I said, sometimes there is no problem within the heart. It's just turbulent blood flow, and that can produce a murmur. So that was the confusion when we heard a systolic murmur. In a systolic murmur, it could be pathological or it could be non-pathological. The heart may be totally normal, and yet, for example, in anemia, in thyrotoxicosis, beriberi, any condition where there is hyperdynamic circulation, there may be abnormal sound produced due to turbulence, not because the heart is abnormal, just that the disorder is producing a hyperdynamic circulation. So that would produce a systolic murmur. Whereas a diastolic murmur almost always indicated that there is an intracardiac pathology. A diastolic murmur, when you hear, you are certain that it's an intracardiac pathology. So that's why you never needed to grade it. Whereas systolic murmurs, if it was grade 4 and beyond, definitely it meant there is an intracardiac pathology. Grade 4 and beyond definitely meant that there is an intracardiac pathology. Up to grade 3, you could have it even, like, for example, in severe anemia. So this was the traditional teaching. Now, of course, grading is accepted even for diastolic. So, but you have to use your judgment. Your examiner may not agree. So you stick to what is the traditional teaching. If the examiner asks, can you grade? Then yes, you can say, yes, it can be graded using the same system also. Okay, so the only reason we were not doing it earlier was because diastolic murmurs were thought that it was always suggestive of an intracardiac pathology, whereas systolic need not have. But now the viewpoint is even diastolic murmurs may be functional. They may be flow murmurs. So diastolic murmurs may be flow murmurs. So that is why even the current teaching is you can grade diastolic murmurs also. Okay, so it can be flow murmurs. No harm in grading even a diastolic murmur. Okay, so that's the I part of the mnemonic intensity. P. P is for pitch and position of the patient. So remember for mitral area murmurs, whether it's mitral regurgitation or mitral stenosis, mitral area, you need to put the patient in left lateral. That is the best way to auscultate a that I'm talking about the position of the patient. Okay, the patient needs to be lying in left lateral position, and then you can auscultate for the mitral area for mitral area murmurs, both MR and MS. Okay, MR and MS. Whereas for aortic area or aortic valve murmurs, you can have the patient seated and leaning forward. So bending forward, seated and leaning forward. So for AR and AS, this is a better position, AR and AS. Okay, that's the positioning of the patient. Pitch. So low pitch murmurs and high pitch murmurs. Remember, for low pitch sounds and low pitch murmurs, you need to use the bell of your stethoscope. So low pitch murmur examples are mitral stenosis and aortic stenosis. So aortic stenosis, it's a little debatable. Some sources say it's high pitched, whereas some sources say it's low pitched. But then I have written it as low pitched only. Harrison's mentions it as a low pitched murmur, so I've gone with that. Whereas high pitch is for MR and AR, okay, and VSD for that matter. So remember, murmurs are not just because of valvular problems. It can be because of septal defects also, and sometimes other pathologies. We'll come to that. So high pitch is MR, AR, VSD, etc. Low pitch is MS and debatably AS. These are low pitched murmurs. Okay. One more thing you should keep in mind is how to differentiate right-sided murmurs from left-sided murmurs. So remember, right-sided murmurs increase in intensity with inspiration. Intensity with inspiration. Whereas the opposite true for left side murmurs. Left side murmurs, they increase in intensity with expiration. All to do with the blood flow. In inspiration, reduced venous return, more blood flowing into the right side of the heart, therefore causing the left side of the heart to be compressed by the interventricular septum. Less blood flow in the left side of the heart during inspiration. Right side murmurs intensity increases, left side murmurs intensity reduces in inspiration. Everything opposite with expiration. So left side murmurs intensity, rather it reduces in inspiration, but increases in with expiration. So left-sided increase intensity with expiration. Okay. These are just a few points when you're trying to auscultate murmurs. Okay, and timing. So timing, as I said, is one of the most important points to describe a murmur. In fact, it can be very confusing also. So timing means, is it a systolic murmur or is it a diastolic murmur? This is the most important way to classify murmurs. Is it systolic? Is it diastolic? How do you make out? So any murmur that occurs between S1 and S2 is systolic, whereas anything that occurs between S2 and the subsequent S1 is diastolic. For that, you should be able to appreciate the murmur one, but also try and time whether it is when is the murmur coming. Is it before the S1, after the S1? How do you know when an S1 is happening? You're hearing two sounds. Lub dub. Which one is S1? Which one is S2? Whatever corresponds with the apical impulse or carotid impulse. So if you're auscultating the heart, you place the chest piece on the patient's heart and you're palpating the carotid. When the murmur comes, if the murmur comes after the carotid impulse, then it is systolic. If the murmur comes before the carotid impulse, that means the murmur came and then the carotid impulse came, then it's a diastolic. So these are things that initially you may have difficulty in picking up, but as you hear more and more, so even as a first year resident, first year postgraduate, I could still not confidently tell which murmur I was hearing. Okay, so it took me a long time, repeated auscultation, repeatedly going to the ward and seeing patients. Even though they were admitted, I had to repeatedly auscultate. Even at the end of the first year also, I was not confident. Only in my second year was I able to really be confident in telling this murmur must be because of this lesion. And then as your confidence increases, you can actually make new diagnosis. So patient who was never diagnosed before, you heard the murmur, you sent the patient for echocardiography, you had a suspicion, and then your diagnosis turned out to be correct. So that also happens. But that it takes experience, it takes repeated practice. So initially, even though it may seem difficult, the more you see, the easier it becomes. Okay, so any event that happens between S1 and S2 is systolic. Any event that happens between S2 and the subsequent S1 is diastolic. Okay, so you need to classify based on the timing. Is it a systolic and diastolic? Again, in systolic, there is pan-systolic, ejection systolic, early systolic, late systolic. And in diastolic, there is early diastolic, mid diastolic. So you need to be able to differentiate between the two. But these are broadly, systolic and diastolic are the broad subclasses in murmurs. Okay. So we will focus a little bit on that from now on. So between systolic and diastolic murmurs, what are the differences? So as I said, traditionally the view was diastolic murmurs are always pathological. Diastolic murmurs are always pathological. But sometimes it's not an intracardiac pathology that is producing a diastolic murmur. And that's why no longer are we restricting the grading or intensity defining definition for a murmur to be restricted to only systolic murmurs. Even diastolic it is being graded. So traditional view was diastolic murmurs are always pathological, systolic murmurs need not be, and therefore even if the systolic murmur has grade 4 and beyond, then it is and then it's a pathological murmur, otherwise may not be. That's why the grading also applied. So grade 4 and beyond is always suggestive of a pathology, systolic or diastolic. Okay. So as I was saying, grade 4 and beyond for a systolic murmur is always pathological, and so too for diastolic. If there is a thrill, if you can palpate a thrill along with the audible murmur, then definitely it must be a pathology, intracardiac pathology. Radiation. Now, traditionally, when the ventricle contracts, it contracts with a lot of force, whether it's a right ventricle or left ventricle. It contracts with a lot of force. So that is why a systolic murmur occurs when the left ventricle or the right ventricle contracts. Right. So a systolic murmur has more potential for radiation and conduction. The turbulence produced is much more, and therefore it allows the sound to get radiated and conducted. So generally, a systolic murmur will radiate or conduct more likely than a diastolic, which is true. In fact, as I told you, mitral stenosis murmur, which is a mid-diastolic murmur, very well localized, doesn't go anywhere apart from the apical impulse, not audible anywhere else. Whereas systolic, like for example, aortic stenosis, it conducts to the apex, it radiates to the carotids. In the case of mitral regurgitation, which is again a systolic, pan-systolic murmur, it radiates to the left axilla, it radiates to the back, can radiate to the base based on the, depending on the leaflet which is damaged. So radiation is generally more true for systolic, whereas not so for diastolic. And then finally, the eponymous murmurs. So which are the eponymous murmurs? Most of the eponymous murmurs, okay, that means named murmurs. If the murmur has been given a name, it's named after somebody's physician or a cardiologist, then most likely it is a diastolic murmur. Most named, famous named murmurs are diastolic. Okay, there are exceptions, I'll agree, but most named murmurs are diastolic. Okay, for example, let's discuss which are the named murmurs that we commonly you are asked and commonly discussed clinically. Caricomb murmur is what is found in acute rheumatic fever. It's a mid-diastolic murmur. Acute rheumatic fever, mid-diastolic murmur. Okay, it's an MDM, mid-diastolic murmur. Austin Flint murmur, that again is mid-diastolic murmur, which is heard in aortic regurgitation. Aortic regurgitation. So in aortic regurgitation, I'm sorry about the spelling, aortic regurgitation, there is a regurgitant jet. Okay, so for example, let me show it like this. If this is the mitral valve, this is the left ventricle. Okay, this is the left ventricle. Okay, this is the left atrium. And let's say, let me represent the aorta over here. Okay, let me show it like this. This is the aorta, this is the LV, and this is the LA. Now, if the blood is flowing, normally it's supposed to go only unidirectionally from left ventricle into the aorta and then forwards. Once the aortic pressure rises more than the LV pressure, LV chamber pressure, the aortic valve should close, right? So aortic valve, which is a semilunar valve, three cusps, it will close due to the pressure difference. It's a one-way valve. Let's suppose it's damaged and it's allowing backflow. So this regurgitant jet, once the systole is over, the diastole is starting, but the valve is defective. The aortic valve is defective. This jet of blood during aortic regurgitation will fall on the mitral valve. And what will that do? What is supposed to happen in diastole? The aortic valve is supposed to close and the mitral valve is supposed to open. But this regurgitant jet is falling directly on the mitral valve. It is impinging on the mitral valve, not allowing it to open, entirely open, which will produce a type of relative mitral stenosis. It's not absolute mitral stenosis. It's just there's nothing wrong with the mitral valve. But because the regurgitant jet is impinging on the mitral valve, not allowing it to open fully during the diastole, it will produce a narrowed mitral valve opening, producing an MDM. That is known as Austin-Flint murmur. Austin-Flint murmur indicates that this aortic regurgitation must be severe. So how do you make out if the aortic regurgitation is severe or not clinically? How can you tell? If there is an associated Austin-Flint murmur, so severe that it is producing a relative mitral stenosis. Okay, so this is again an MDM produced in AR, not because of the aortic valve per se, it's because of the jet falling on the mitral valve and not allowing it to open fully during diastole. So that's an Austin-Flint murmur indicating this a severe AR. Gram-Steele murmur is a functional PR, pulmonary regurgitational, functional pulmonary regurgitation. This is seen in, it's an early diastolic murmur. It's an early diastolic murmur. It is seen in pulmonary hypertension. Pulmonary hypertension. So Gram-Steele murmur is a murmur of pulmonary hypertension, which occurs due to a functional pulmonary regurgitation. It's an early diastolic murmur. Best heard in the left third parasternal space, an early diastolic murmur in pulmonary hypertension indicates Gram-Steele murmur. Gibson's murmur, you guys know, Gibson's murmur is not truly diastolic. It is a continuous murmur. It's the machinery murmur. It's the machinery murmur, which is seen in patients or which is appreciated in patients with PDA. Machinery murmur, continuous murmur, right? It not just lasts in systole, it continues through the S2 into diastole. So machinery murmur of PDA is known as Gibson's murmur. Okay, right hand murmur. Right hand murmur is again an MDM, which is produced in patients with third degree AV block. Third degree AV block. Okay, third degree AV block. This is right hand murmur. Okay, it's an MDM again. So as you realize, most of these famous named murmurs, they're diastolic murmurs. Okay, not systolic. Could argue Gibson's has a systolic component, but also has diastolic because it continues throughout the systole and into the diastole, crosses over from S2 along beyond S2 into the diastole also. Okay, so these are the named murmurs and most of them being diastolic. Okay, coming to pansystolic murmur. So discussing briefly the systolic murmurs, then briefly the diastolic murmurs. Systolic murmurs, pansystolic murmurs, which means how will you describe the pansystolic murmur? So if you hear the S1 and the S2, if the murmur seems to last throughout the systole, right from the beginning of S1 till the occurrence of S2, which means you can't clearly make out the difference, the gap between the occurrence of S1 and the start of the murmur. Okay, this gap is non-existing. Then, and likewise, even the gap between the end of the murmur and the occurrence of S2, if that gap is non-existing, then it is a pansystolic or a holosystolic murmur. Pansystolic murmur lasts right from the S1 till the S2, no gaps anywhere in between throughout the systole. It's an pansystolic event. Okay. Usually, if it is associated with, if it's a mitral regurgitation, you'll appreciate that the S1 is soft. So soft S1, you can barely make out the first heart sound. Yet there is some turbulence that you can pick up. It's a blowing murmur, which is high pitched and it lasts with the same intensity till S2. You can't make out where the S2 is. You can just make out a continuous murmur throughout the systole. Okay. So it'll start with a very soft first heart sound. Then it will continue as a blowing, rough, high-pitched murmur. So it'd be like this. In fact, mitral regurgitation is very common. You can easily pick it up. I'm sure if you continue auscultating patients in the ward, in the OPD, in the emergency room, in the ICUs, you will pick up mitral regurgitation in at least one patient. Okay, it's very common. In fact, the most common cause of mitral regurgitation right now is secondary MR. Secondary MR due to dilated cardiomyopathy. Okay, as the most common cause. Otherwise, rheumatic mitral regurgitation can still be seen in India also, but in the West, it's overwhelmingly secondary MR that is common. MVP is yet another cause for MR. Okay, mitral valve prolapse. Mitral valve prolapse can present slightly differently. We'll discuss that subsequently, but mitral regurgitation could be rheumatic, could be secondary. Secondary is most common worldwide. In India, still rheumatic MR is prevalent. Okay, rheumatic heart disease causing mitral regurgitation. So the pansystolic murmur starts with a soft, if it is due to mitral regurgitation, starts with a soft S1, lasts throughout the systole, and ends with S2. Can't make out the gap between the S1 and onset of the murmur or the end of the murmur and the S2 occurring. Okay. If it is mitral regurgitation, the murmur will radiate towards the back and the left axilla. Tricuspid regurgitation, again, will be very similar to mitral regurgitation, like this, beginning of S1 all the way to S2. And again, the S1 would be soft. Okay. Tricuspid regurgitation is more localized, not as doesn't radiate as much as with the mitral regurgitation, as the case is with the mitral regurgitation. Ventricular septal defect is yet another cause of pansystolic murmur. The difference being the radiation here is towards the right parasternal space. So remember, we discussed that the murmur will radiate along with the jet. Wherever the jet is going, there the murmur has the chance to get radiated. So in the case of ventricular septal defect, it is a left to right shunt. It is a left to right shunt. So that is why the murmur will radiate towards the right parasternal space. You will hear a pansystolic murmur. Most likely, it will be in the tricuspid area. So in the left fourth parasternal space is where you hear the murmur, but it will radiate towards the right parasternal space. So that is how you differentiate it from tricuspid regurgitation. Tricuspid regurgitation, more localized, it will stay where it is. And it will be associated, tricuspid regurgitation has its own unique clinical features, including pulsatile liver. You can also get JVP changes. For example, these are systolic pulsations that you can appreciate in the liver if the liver is enlarged. And then JVP changes, you can see the obliteration of X descent, the prominent CV wave in JVP. Those are JVP findings. It's called Lancey sign. So those findings will also be there if it's a TR. If it's a VSD, pansystolic murmur, best heard in the left fourth parasternal space, but radiating towards the right parasternal space. So that is one difference. Okay. Now, just before we proceed, this is something interesting that happened. One of my students, he was auscultating a relatively young lady, a 35-year-old lady. She was a little reluctant to allow him to auscultate the front of her chest. So she just sat with showing her back. So he was auscultating the back. In the back, he could hear a murmur. So almost immediately he was taken aback because you don't expect murmurs to be heard in the back. So he was a little excited. He thought maybe it's coarctation of aorta. So he was telling, he called us and he was discussing that maybe we should look for other signs like Sussman sign. Sussman sign in coarctation aorta is pulsatile arteries because of presence of collaterals in the back. So pulsatile arteries in the back. And generally this murmur that we hear in coarctation of aorta is again because of the collaterals only, especially in the angle of the scapula. So angle of scapula is where you can pick up, angle of left scapula is where you can pick up this murmur again because of collaterals opening up with the coarctation. But all he had to do was request the lady to auscultate the front also. So as soon as we auscultated the front, you could clearly make out that there was a pansystolic murmur that was present in the apical area, in the mitral area. Okay, so apical pansystolic murmur, which was radiating to the left axilla, radiating to the back. So anytime you hear a murmur in the back, the first thing you should think of it, mitral regurgitation. Maybe if you rule that out, then you can think of coarctation of aorta. So this was a funny little incident that happened. Okay, one more case. This is of course not a true case, but a simulated case. Supposing a 60-year-old man developed abdominal pain and vomiting, then followed by breathlessness, bilateral crepitations with an early systolic murmur. We discussed about pan-systolic murmur. What about if you hear an early systolic murmur? So why is the murmur pan-systolic in mitral regurgitation? In mitral regurgitation, it is from the left ventricle, the blood regurgitating into the left atrium. So at any given time, the left atrial pressure will always be lesser than left ventricular pressure. In chronic MR, okay, chronic MR, left ventricle will dilate. It has time. So left ventricle will slowly dilate to try and maintain the forward flow, forward ejection fraction. Okay, so what happens in left ventricle with mitral regurgitation, chronic mitral regurgitation is because there is some amount anyway going back, the left ventricle tries to increase the end diastolic volume. By increasing the end diastolic volume, at the end of the diastole, if it is well dilated, then yes, something is going in a retrograde manner, no problem. At least let us maintain the forward flow. That's the aim of in chronic MR of the left ventricle. The left ventricle knows that some amount is going to be lost into the left atrium. At least let us maintain good forward flow. That is why it dilates. It holds more at the end of diastole just to compensate the forward flow. So it is maintaining a forward flow by dilating. This is only in chronic MR. Okay, chronic MR, the difference between the pressures of the LV and the LA is throughout the systole. That's why the pan-systolic nature of chronic MR, chronic mitral regurgitation. Pan-systolic, throughout the systole, the difference is there between the left ventricle and the left atrium. The blood flows throughout the systole. But what if there is an early systolic murmur in the mitral area audible? With this kind of a clinical picture, the ECG as shown. What can you make out in the ECG? Can make out that there is elevation, ST elevation in 2, 3, and AVF. Clearly, there are ST elevations, right? I'll zoom it in for better appreciation. Now, 2 and 3, 2, 3A and AVF are showing ST elevations, and the patient has also presented like that, abdominal pain, vomiting, consistent with inferior wall MI. So 2, 3 AVF are inferior leads. There is an inferior wall MI. Along with this, patient has developed breathlessness and an early systolic murmur. What could this be pointing to? In inferior wall MI, patient can be prone for papillary muscle rupture leading to acute mitral regurgitation, acute MR, because of posteromedial papillary muscle rupture leading to acute MR. In an acute mitral regurgitation, there is no time for compensation. There is no time to dilate. There is no time to increase end diastolic volume. Therefore, the left ventricular pressures will equalize with the left atrium very early. That's why the murmur is only early systolic. So remember, early systolic murmur is heard in MR if it is an acute MR. Chronic MR, it's pan-systolic. Acute MR is early systolic. And these will be the typical clinical features. They'll have breathlessness because of pulmonary edema. Now, blood is flowing back into the left atrium. Left atrium cannot hold it. There's no time. It can't dilate. Left atrium cannot hold this excess amount of blood. It can't dilate. It has no time. So it will pass on this pressure into the pulmonary capillaries, pulmonary vein, and then pulmonary capillaries. And from the pulmonary capillaries, there will be transudation of fluid into the alveoli, leading to pulmonary edema, causing breathlessness and acute MR. It's a surgical emergency. An acute MR is a surgical emergency. Okay. So this is a variation of mitral regurgitation, acute MR. Acute MR can be caused by MI. It can be caused also by infective endocarditis. Okay. And in that case, the murmur will not be pansystolic. It will be early systolic. So sometimes the murmur can be late systolic. So this mitral regurgitation murmur has so many variants. Okay. If it is pan-systolic, it is chronic MR. If it is early systolic, it is, early systolic, it is acute AR, acute MR. And if it is late systolic, it is because of MVP. So mitral valve prolapse is again a cause for mitral regurgitation, but the murmur will generally be late. It will be after the click. So there'll be a mid-systolic click followed by a murmur, and it will be late systolic. So late systolic murmur is seen in mitral valve prolapse, especially the murmur following the click. And this is where you need to use a method known as dynamic auscultation. So in MVP, the mitral regurgitation murmur will follow certain patterns on dynamic auscultation. So you should, any systolic murmur you hear, no, whether it's ejection systolic or pan-systolic murmur, or let's say a late systolic murmur, if you hear a systolic murmur, left-sided heart disease producing a systolic murmur, you should use dynamic auscultation, because the ejection systolic murmur may be caused by something known as HOCM, hypertrophic obstructive cardiomyopathy. This also has certain unique features in dynamic auscultation. Likewise, PSM, pan-systolic murmur, also has unique features on dynamic auscultation, especially when it is caused by MVP, mitral valve prolapse. So what are these dynamic auscultation maneuvers? How can you remember them? So remember this small story. Once the children, instead of attending school, they were seen playing marbles. Okay, what is the kid doing to play marbles? He's squatting, right? So squatting and playing marbles. They were gripping their hands and playing arm wrestling, and some were just putting their feet up and relaxing. So instead of attending school, these children were squatting and playing marbles, gripping hands and playing arm wrestling, and keeping their feet on the table, feet up on the table, and relaxing. That's when the mother came in. Okay, and the mother was very angry. What are you kids doing instead of going to school? You are playing and relaxing here. And that is when the kid said, actually, we have won the most valuable player award in sports. And that is why we thought, instead of going to school, we'll do all these. Okay. So obviously, this story is not a good message to kids, but it's just an attempt for you to be able to remember that these are the maneuvers with which the MVP murmur will reduce. So these murmurs, or these maneuvers rather, will reduce the MVP MR, or MR associated with MVP murmur. So, or rather the MVP associated MR murmur intensity. So what dynamic maneuvers, auscultation maneuvers, will reduce the intensity of the MVP associated MR murmur? Squatting, leg raising, and hand grip. With these, there is a reduction in intensity of the murmur with MVP. Likewise, even in HOCM and MVP, these maneuvers will produce a reduction in the murmur intensity. Please keep these maneuvers in mind. Okay, what will increase the intensity of these murmurs? It will be Valsalva. So Valsalva, strain phase of Valsalva will increase. Valsalva will increases the murmur intensity, MR, of MVP, and HOCM murmurs. Okay, these are unique exceptions. Every other left-sided murmur will increase when a patient with left-sided murmur due to any other cause apart from MVP or HOCM, any other systolic left-sided heart disease murmur, systolic murmur, the intensity will increase with squatting, increase with hand grip, and increase with leg raising, except HOCM and MVP. Okay, the systolic murmurs of MVP and HOCM will reduce with these maneuvers. Keep that in mind. And likewise, Valsalva maneuver will reduce the intensity of every other left-sided systolic murmur, except MVP and HOCM, where the intensity actually goes up. Okay, just an attempt for you guys to be able to clearly remember that these are the dynamic auscultation maneuvers and their relation to only MVP and HOCM. Okay, every other left-sided systolic murmur will be opposite to what we just discussed for MVP and HOCM. Okay, so that is about mitral regurgitation and its variants, acute, chronic, and MVP-related systolic murmurs. What about ejection systolic murmur? Ejection systolic murmur is nothing but mid-systolic murmur. So when we talk about S1, S2, if it is an early systolic murmur, it will occur right in the beginning. Okay, and then immediately the left atrial pressure will rise so much that the murmur will stop. The blood flow, the turbulence will stop. All the regurgitation will happen early in systole, then it will stop. If it is a late systolic murmur, it will be towards the S2 part. Clearly, nothing in the beginning, but towards the end, towards the S2, you will hear a murmur. That is late systolic murmur. And that too, it will happen after a click. Okay. In MVP, there is a click that you hear. then the murmur starts and ends at S2. If it occurs only in the middle, then it's called ejection systolic murmur. That means in injection systolic murmur, there is a clear gap between S1, then the onset of the murmur, then the murmur ends, and then there is S2. So in fact, this is known as a crescendo decrescendo murmur. So if this is S1 and this is S2, the ejection systolic murmur is something like this in shape on a phonocardiogram, or rather, when you depict the phonocardiographic recording, it'll seem like this. So it's a crescendo decrescendo murmur of aortic stenosis. So what you hear is basically here, mid systolic part you hear, okay, which you can pick up. That's an ejection systolic murmur. That is because of aortic stenosis. Okay. Now, aortic stenosis may be valvular aortic stenosis, which means it is best heard in the second right parasternal space and radiates to both carotids equally. Both carotids, right and left carotids equally. Subvalvular AS is actually best heard in the third left parasternal space, which means in the Mbbs area. So in the Mbbs area, if you're hearing an ejection systolic murmur, best intensity, maximum intensity you're hearing in the left parasternal space, third parasternal space, then it's likely to be subvalvular aortic stenosis. Same ejection systolic murmur. Okay, if you're doubting HOCM, subvalvular AS is one of the causes is HOCM. So if you're doubting that it may be HOCM, then you have to use dynamic auscultation. Remember, hand grip, leg raising, and squatting. That will reduce the intensity of the murmur. Supravalvular AS is again best heard in the second right parasternal space, but radiates more to the right carotid than the left carotid. This is due to something known as Coanda phenomenon. Coanda phenomenon is it's to do with hemodynamics. Okay, rather it is flow dynamics. Because we're talking about blood, it's hemodynamics. But flow dynamics has this principle called Coanda phenomenon, which with supravalvular aortic stenosis, all you need to know is it will direct the blood more towards the right side than the left side. That's called Coanda phenomenon. That's why the murmur will radiate more towards the right than to the left carotid. That is with supravalvular AS. Remember, the association of supravalvular AS is with something known as Williams syndrome, hypercalcemia, Elfin phases, and all that. So supravalvular AS, clinically, the difference is same site, but radiation more towards the carotid. Subvalvular AS, more in the Mbbs area. If it is aortic valve AS, then it is right second parasternal space with radiation to both carotids. May conduct to the apex. That's called Gallagherdian phenomenon, musical character of the murmur conducting to the carotids. Okay. So aortic stenosis murmur, not difficult. Okay, aortic stenosis murmur is also easy to pick up. Very rough murmur. You can easily pick it up. Mitral regurgitation also easy to pick up. Blowing murmur, very common, very commonly heard, very commonly present. Okay, so systolic murmurs generally not an issue in terms of detecting. As you are beginning to hear more and more patients, you'll easily pick these up. Diastolic murmurs, on the other hand, both are difficult. I'm talking about the valvular diseases. That means mitral regurgitation and mitral stenosis and aortic regurgitation. Both cause diastolic murmurs. Both are difficult to pick up in the beginning. Okay, as a beginner, it may be slightly more challenging to pick these diastolic murmurs up. So, and in terms of diastolic murmurs, there is mid diastolic and early diastolic, which we'll discuss. Mid diastolic murmur, generally it is rumbling character. So how does it sound? How does the murmur actually sound? It'll be like grrr. Okay, so it's like a rumble, and it will have a presystolic accentuation, especially if it is due to a mitral stenosis. So if it is due to mitral stenosis, it will be associated with a presystolic accentuation. So if I had to draw and describe it, if this is the S2, subsequent S1, if it is mitral stenosis, it will start in the mid diastole and increase in intensity just before S1. Why this increase in intensity? That's because the left atrium will contract just before the S1. Okay, during the diastole, the late rapid filling phase of diastole, the left atrium will contract. And this will force the blood through the narrow mitral valve area. Okay, so that will produce an increase in the turbulence, an increase in the intensity of the murmur. So that's called pre-systolic accentuation, PSA, which is a feature of mitral stenosis. So in a mitral stenosis, expect that there is a mid-diastolic murmur, rumbling murmur, very localized, low-pitched murmur. You need to use the bell of your stethoscope, and that will increase in intensity just before S1. That's called pre-systolic accentuation. In fact, in mitral stenosis, you may even hear an additional diastolic high-pitched sound, which is known as opening snap. Okay. So overall, it will be an opening snap after S2. So there will be an S2, an opening snap, the start of a mid-diastolic murmur, which increases just before S1, and the S1 will be loud. I told you in mitral regurgitation, S1 is soft. In mitral stenosis, S1 is loud. Okay, so overall, it will sound like this. Drrrk, diduk, drrrk, diduk. Okay, so the murmur is drrrk. It's a mid-diastolic murmur, rumbling murmur, which increases just before the S1 happens. Drrrk. That's the first hard sound, very loud. Diduk. Okay, diduk means the first sound is S2, the second sound is the opening snap. So this is what you can try and appreciate in mitral stenosis, a mid-diastolic murmur with pre-systolic accentuation, low-pitched diastolic sound. Okay, let's consider this particular case. A 35-year-old lady complains of breathlessness that worsens on sitting up and relieved on lying down. Examination reveals an irregular pulse with a mid-diastolic murmur on cardiac auscultation. Opening snap is absent. What do you guys think could be causing this murmur? It's an MDM, right? The first thought is always, and along with that, there's irregular pulse also. So the first thought is always, it might be mitral stenosis, correct? What's odd about mitral stenosis? Okay, opening snap is absent, not heard. But is that enough to disqualify mitral stenosis? The one glaring point is this piece of history, that the breathlessness is there, but it worsens on sitting up and relieved on lying down. That is known as platypnea. Is that what you see in patients of mitral stenosis? No. Mitral stenosis, generally you see orthopnea. Orthopnea and PND is common in mitral stenosis. Platypnea is a feature of, okay, so there are different causes. Platypnea in with regards to the liver can be seen as a feature of hepatopulmonary syndrome. But with regards to the heart, it is a feature of mitral, or rather left atrial myxoma and left atrial ball valve thrombus. So left atrial myxoma or a thrombus. Okay. So now having known this fact, platypnea may be a feature of, so what's happening if this is the left atrium, this is the mitral valve, okay, and this is the left ventricle. If there's a myxoma here or there's a ball valve here, when the person is lying down, this can shift backwards. It can go away from the mitral valve, allow blood to flow from the left atrium into the left ventricle. When the person stands, as the person stands, this ball valve will come and lodge in this mitral valve opening, and that will produce reduced blood flow from the left atrium into the left ventricle. So gravity is the problem. With gravity, as the person stands, the obstruction of the mitral valve will manifest if there is a left atrial myxoma or a left atrial ball valve thrombus. So that is why the person would prefer to lie down and not sit or stand. That's called platypnea. Platypnea is a feature of left atrial myxoma and left atrial thrombus. Now, is there a reason for left atrial myxoma in this history? Not much. But what about thrombus? Yes, there is. So if it's irregular pulse and if it denotes atrial fibrillation can lead to left atrial thrombus formation. That's because the left atrium is not contracting, it is just fibrillating, leading to stasis of blood, producing a thrombus. So if you hear an MDM in a patient who is complaining of platypnea, you should think of left atrial thrombus. Okay, so remember, there are other causes of MDM apart from mitral stenosis. So orthopnea with tapping apical impulse, always think of mitral stenosis, no doubt. Instead, if there is platypnea with tapping apical impulse, you think of left atrial myxoma and thrombus, left atrial thrombus. What if there is a MDM and an hyperdynamic apical impulse. Hyperdynamic apical impulse is not a feature of mitral stenosis. Mitral stenosis does not touch the left ventricle. Apical impulse should be tapping in mitral stenosis. So if you hear an MDM with the hyperdynamic apical impulse, it may be severe mitral regurgitation or severe aortic regurgitation or a very large VSD. Okay, which means MDM is not the only murmur that you'll be hearing. You must be hearing a pansystolic murmur, or an early diastolic murmur. Because MDM, the basic principle is, if this is the mitral valve opening and there is X amount of blood trying to flow through this, normally it's X. What if this opening is narrowed and X amount of blood is trying to flow through the narrow opening? That will produce turbulence. This is what you see in mitral stenosis. What if instead instead of X, it is 3X amount of blood trying to flow through the normal opening of mitral valve. Mitral valve opening is fine, but relative to the opening, the amount of blood trying to flow through it is more. Then again, the same turbulence is produced. But this is because of increased flow across the mitral valve, which can occur in mitral regurgitation. In MR, too much of blood is flowing back into the left atrium, and all that blood now wants to come back into the left ventricle. So that will produce a functional MDM, a flow MDM. Likewise, if there's a large VSD, left to right shunt, from the right ventricle, the blood will flow through the pulmonary artery, capillaries, pulmonary veins back into the left atrium. And again, large amount of blood trying to flow from the left atrium into the left ventricle through the mitral valve. The mitral valve area is normal, but the amount of blood trying to flow through it is more. So that will produce a turbulence. Again, VSD will produce a hyperdynamic apical impulse. Mitral regurgitation will produce a hyperdynamic apical impulse. Aortic regurgitation we already discussed. This is known as Austin-Flint murmur because of impingement of the regurgitant jet on the mitral valves, not allowing it to open fully. Okay. That is about mid-diastolic murmurs and the different causes. Remember, Carey-Combe murmur is also mid-diastolic. Austin-Flint murmur is also mid-diastolic. And then the other causes we just discussed. Okay, what about early diastolic murmur? Which means after S2, there is a murmur that starts and then reduces in intensity progressively. That's called a decrescendo murmur. Remember, crescendo, decrescendo is aortic stenosis. That is in systole. A decrescendo murmur heard in diastole is early diastolic murmur. Right in the beginning of the diastole, early part, there's a murmur that's early diastolic murmur. And if it is as a result of aortic or pulmonary regurgitation, it will be blowing in character. Now, the problem with this early diastolic murmur of aortic regurgitation is very difficult to pick up. It sounds very much like breath sounds. Okay. So what you will mistake that sound is to be the patient's breath sounds, the vesicular breath sounds. It sounds just like that. It's blowing characters just like the breath sounds. That's the sound. Okay, so that's how it appears on auscultation. So aortic regurgitation murmur sounds very much like a person's breath sound. So that's why you need to have a high index of suspicion that the patient may be having an aortic regurgitation. If necessary, ask the patient to hold breath for a few seconds to distinguish whether it was vesicular breath sound or whether it was AR murmur, the blowing AR murmur, early diastolic murmur. So that is why both MS and AR can be difficult to pick up for different reasons. MS, it's very localized and low pitched. Whereas aortic regurgitation, it sounds, because of its blowing character, sounds very much like the person's vesicular breath sounds. So ask the patient to hold breath. That will clarify your doubts. If you're confused whether the sound you're hearing is AR murmur or the patient's vesicular breath sounds. Okay, so best heard aortic regurgitation. The murmur is best heard in the left third parasternal space. Same as pulmonary regurgitation. Both murmurs are heard in this space only. How do you distinguish between these two? Ask them to take breaths, right? So if the murmur increases with inspiration, it will be because of pulmonary regurgitation. That's called Carvalho's phenomenon. So de Carvalho's phenomenon is right side murmurs increase in intensity with inspiration. In fact, not just murmurs, all right side heart sounds or right sided auscultation findings will always increase with inspiration. Left sided auscultation findings will always increase with expiration. Okay. So this is about early diastolic murmur. It's usually well localized. It's in the left third parasternal space, Erb's area. That's where you hear it. Okay, just a word for completion's sake on continuous murmurs. So anything that starts off in the systole, generally continuous murmurs will be throughout the systole and will carry over into the diastole. That means beyond S2 into a part of the diastole. Okay, this is known as a continuous murmur. Continuous murmur starts off in the systole, lasts throughout the systole, and then crosses the S2 into the diastole, part of the diastole. It need not be throughout the diastole, but at least beginning of the diastole, it will be there. That's called a continuous murmur. The causes are patent ductus arteriosus. It's called Gibson's murmur, machinery murmur, continuous murmur. Rarely coronary AV fistula. That can also produce a continuous murmur. Okay, so I won't describe too much of this. So patent ductus arteriosus, if you're hearing the best side to hear the PDA murmur would be in the left second parasternal space, sometimes even in the first space. So left second, sometimes the left first parasternal space or the intercostal space, you can hear a continuous murmur with the maximum intensity there. And that will be throughout systole, carrying over into diastole. And associated with the PDA would be findings of wide pulse pressure. So if you're suspecting PDA, some suspicion of congenital rubella or other syndromes, and you think there's a chance that the patient has a PDA, you're hearing a murmur there, continuous murmur right from S1 through S2 into the diastole, part of the diastole, then you should check for wide pulse pressure signs. Okay, wide pulse pressure. That means systolic is very high, diastolic is very low. Coronary fistula is yet another rare cause, very rare cause of continuous murmur. Rupture of sinus of Valsalva is another cause for continuous murmur. But these are all sort of complicated, rare causes for wide pulse pressure. So for continuous murmur, I'm sorry. So just before I end, a couple of questions. So can you guys tell me? I'll give you just brief amount of time, or you can pause the video and you can think of the answer before I tell you. So if there is an early diastolic murmur heard in a patient, there is an early diastolic murmur along with a mid diastolic murmur. What could the diagnosis be? An early diastolic murmur in the Erb's area and a mid diastolic murmur in the mitral area. The diagnosis most likely, is it AR with MS? Need not be. Okay. Generally, if the mitral stenosis is severe, it will not allow the AR to manifest only. It will not allow the blood to flow from the left atrium into the left ventricle in a significant amount for the AR to manifest. So having this combination is uncommon and unlikely, not likely to happen. The hemodynamics will not allow it to occur. Instead, this is more likely to be AR with Austin Flint murmur. Okay. So if you hear early diastolic murmur in the Erb's area and mid-diastolic murmur in the mitral, it's probably AR, severe AR, producing Austin Flint murmur. Next, what if there's a pansystolic murmur in the left parasternal space with early diastolic murmur in the Erb's area? This is slightly tough. I'm not sure if it's easy to guess this or to get this right. So, but let's say I'll give you a little more clue. So the left parasternal, fourth parasternal space, that murmur is radiating to the right, parasternal space, which makes it VSD. So basically a VSD with an early diastolic murmur in the Erb's area, so which means a VSD with aortic regurgitation. Can you guys guess? Basically, it's a subtype of VSD. It's a perimembranous type of VSD, which sometimes while closing can cause an aortic regurgitation. So if it doesn't, it due to Venturi effect, it produces an aortic regurgitation. That's a VSD. Okay. So just having fun with a combination of murmurs. So finally, what I would say is murmurs are important from a different, from several points of view, including getting a diagnosis right and screening for congenital heart disease. There are some times where, especially in peripheral health centers, so primary health centers rather, where murmurs have helped to detect an underlying VSD and underlying congenital heart disease. So it's important that you practice and polish your auscultation skills to be able to pick up certain murmurs. For you to suspect, nowadays echocardiography can be done even in the remote areas of India. Maybe not yet all areas, but definitely several places, much more than what we could, let's say, 20 years ago. So if at least you pick it up, you can refer to the higher center for them to be able to diagnose these diseases, including congenital heart disease. Infective endocarditis earlier, change in the murmur used to be one of the major criteria for diagnosis of infective endocarditis. Now it's not. The change in the murmur point is not. But still, infective endocarditis can produce valve dehiscence, can produce acute AR, acute MR. So from that point of view, infective endocarditis diagnosis murmurs do help. Rheumatic fever, rheumatic heart disease, though the incidence has come down a lot compared to, let's say, 3 decades, 4 decades ago, but still it's of importance. And many, many more. For example, in acute MI and acute acute MR can occur in inferior wall MI. So that needs to be dealt with. So if in acute MR, you need to give peripheral vasodilators, and then it's a surgical emergency. You need to operate and correct the patient's underlying coronary artery disease, coronary artery blockage by using PTCA. Or of course, if there's an MR, it needs a surgical correction for the valve replacement. Okay, so with that, remember, it can be daunting. Auscultation, it's a matter of practice. Repeatedly, as much as you can, you should try and auscultate more and more and more patients. Once you know what is normal, picking up what is abnormal becomes easier. But even then, to reach a diagnosis takes a lot of effort. As I said, even I myself, I've struggled. But with practice, with repeated exposure, it definitely does become easier. So don't be discouraged. Try your best. Okay. And the more you apply your knowledge, this is what we discussed now. A lot of it, to an extent, is theory, but there is methods to the madness. When you apply all this in practice, you will realize that it does become easy to sort out what the murmur might be, what it might be indicating. Okay, so with that, we'll conclude today's session. I hope this will be beneficial for you guys in your exam preparation, in your application in the ward, in clinical practice, in the OPD. And if you guys have any doubts, I'd be happy to take them in the comment section below. So happy learning, guys. And from my side, I'll sign off. Good night and take care.